Here's the problem. Healthcare is more complex than ever. New technology is rolling out faster than teams can adapt, staffing is stretched thin, and information is scattered. So what's the solution? It's not just better tools, it's better systems, better communication, and leadership that understands how people, processes, and technology all work together. At the Healthcare Systems Process Improvement Conference, these conversations are happening in real time. Welcome to a special episode of Problem Solved. We're bringing you inside conversations from two keynote voices who approach improvement from different angles but arrive at the same truth. Better outcomes depend on better systems and the people inside them. First, we hear from Dr. Emily Patterson from School of Health and Rehabilitation Sciences at The Ohio State University. Then from Lennox Wildman from the VA in Augusta, Georgia.
Dr. Patterson, thanks for taking the time. You're going to be one of our keynote speakers at the Healthcare Systems Process Improvement Conference in Atlanta. Let's talk a little bit about what your plans are for the conference. For instance, what topic do you plan to talk about in your keynote, and what are you hoping attendees gain from it?
Well, thanks so much for asking. So I actually, broke the keynote speaker rule and asked for an extra day because I think I'm going to learn more from attending the conference than what I have to share. Mm-hmm. So I plan on going to the whole thing and just getting a temperature of what's happening, particularly around ambient AI, listening, and how that relates to quality improvement measures and how large language models are being used and standardization efforts. But what I'm going to share is I worked with many large healthcare systems, and I recently did a very large project with a system that's about to transition to hundreds of sites that have a new electronic health record. And so we have 8 sites that have implemented the electronic health record. I went to 3, and we were looking for what we could learn in primary care for medication reconciliation standardization before implementing the new electronic health record. And so it was a big effort, lots of support from lots of people. It took about 3 months to do. I had a team of about 6 people, and we basically took 3 thoughts. One is standardization and how to get the benefits of reducing multiple ways of doing things and clarifying roles and reducing double work and making it clear where in the system information is going to be found. And then we also took a look on resilience. So for me, work system resilience thinks about how do we have backup people? So if staffing is down today, or if staffing is down at a particular site compared to other sites, how can we have backup roles, delegation roles, and people cross-covering? And this is something that has really emerged in the military. They've been getting very formal about how to do ad hoc teams with electronic support systems. And I'd love to bring that thinking into healthcare, particularly with intake staff doing medication reconciliation, clerks printing medication lists for patients, that sort of thing. And then the other look we're taking is workarounds has a bad name. So people will say, people are super creative in all the ways that they don't do what we want them to do. And so we take a different look. So from a resilience perspective, we think about what positive local innovations can we improve, share, and spread. So we found educational posters in offices. We found lab people who were giving printouts that said, hey, patients, take your medication list and improve it before you come in. Bring your medications with you. And so which of those do we want to take and spread? So what positive deviants, what positive workarounds do we want to share? And then we also did identify negative workarounds that we view as a way to see unmet needs. So just previewing a little bit of our findings at every single step in the workflow that we mapped, every single one, there was somebody who printed a medication list for a patient.
Okay.
And so there's essentially no patient-facing medication list in this electronic health record other than there was one that was hidden that no one knew about for a registered nurse visit before a patient goes to long-term care. And so everyone's been sharing this report for these purposes. And recently the organization standardized the rules, so they said only nurses could print it. All of these other people were printing it. And so our first recommendation was to allow everyone to print it and to improve it. And so they're pursuing that.
Okay. I was curious, you mentioned you're pulling from sort of military background or military operations.
Yep.
How do you determine where to research or find different methods, whether you're looking at the military or you're looking at business or supply chains, anything like that?
Yep. So I am a Human Factors and Ergonomics Society Fellow. So Human Factors is traditionally from aviation, nuclear power, military. That's its home. And so it does work in healthcare, but it's more of an emerging field for us. So we've had a long time of having research in all these other domains. And I personally, in 2000 to 2010, right after getting my PhD, I was working on intelligence analysis, NASA Johnson, military, all versions of the military. And even though I focus on healthcare, I still continue to keep my toe in on, I've had DARPA funding and other funding in these areas. So mostly it's from the human factors literature, but it's also from personal experience in all these other domains.
Well, speaking of human factors, give us a snapshot of your current research in human informatics and communication.
Well, it's a great time to ask because the whole nation is doing their Wile E. Coyote moment where we're like, what are we going to do with research? Actually, the hospitals are a little bit safer space right now, a little bit less crazy, although there's plenty going on there too. But the research has just, undergone a real big shift. And so I think that all of the investment that's going into AI, which is larger than the GDP of the United States, is a real opportunity because a lot of these electronic health records have implemented AI-based or large language model-based things, and they sort of put them in there, and they don't know what the use cases are. So I think I'm particularly well positioned to understand the unmet needs, what are the things that are not being done. There's too much foraging in the chart for what's happening to a patient. Sometimes they don't even know that a patient had a heart attack overnight in the emergency department. It's just really hard to even know what events are. So what are event-driven displays? What are shared displays that we can take advantage of these large language models and knowing the dangers? So with large language models, people will say it's summarizing the chart. It's really not. So it's taking, these models that are created from all these social media sites, and so it can embed that somebody has diabetes who doesn't have it. And so we have to think about carefully checking ourselves. And one of the ways that I would like to pursue is having one large language model check another. So if you have one with the really vetted, and a lot of people are doing this, but people haven't systematized it yet. So if you have, a particularly good language model that's particularly vetted sources, particularly from a medical perspective, maybe tailored to your hospital, it maybe can't do as good of a job, but it can be more accurate. So it can check what it is that comes out.
Yeah, I find that in my work a lot as well, from a communications side, where I'm checking against, like, if I use Claude for an output, but then I check against with ChatGPT, or if I'm certainly in the realm of research, I look at a tool like Notebook LM, and I try to determine, am I really getting the full output or enough context of what I'm actually looking for, but also what is accurate and what is fully factual.
Yeah, and a lot of people in the Human Factors Society have gone so far as to say it's a self-licking ice cream cone. Don't ever use it. It's too dangerous, and a safety system should never have it. But it's being used every day, and it's being helpful every day. While in my own personal experience in the last week, I fell for a scam. I asked for a customer service number from ChatGPT, called it, and it was a scam. So I think it called it up because there's a lot of, spam email that's sent out. So it created a large language model that had this number. And then I typed it into Google and it said, yeah, that's a spam number.
Right.
So number one, I'm never going to do that again. And number two, if I checked the phone number through Google, then I would have been able to find it. So how do we put that in healthcare, basically?
Right. And that's, I think that's of utmost importance, all things considered. What are some of the ways that industrial and systems engineering principles can address human factors and communication challenges in healthcare?
Wow, that's a great question. I mean, I am so happy to be able to go to this conference because I feel like we have a shared mission and really trying to accomplish the same things. And I want to see what ideas are out there at this conference. For me, I always return to communication through a technology to other people is often messed up by structured data fields, particularly if it forces more certainty than the data has to start with. And so always allowing natural text fields, unstructured data fields, ambient communication, ways for people to talk to each other that doesn't have to flow through the database are important. And then a really just fundamental thing is workload and workflow bottlenecks. So I used to just think about workload bottlenecks, like where are people busy, and then they're doing these shedding strategies where they're doing it less well, asking someone else to do it, delaying it in time, doing documentation later. That's well-established research from Huey and Wickens from the 80s. But workflow bottlenecks, I feel like people are just starting to really understand those. And so, for example, and this is not in my keynote speech, but it's another study. If you have the clerks who have to enter information in the emergency department to vet that someone has insurance before you can start, assigning providers and giving medications and prepping the patient, you're never going to have the whiteboard up to date because the clerks also do that. And so that, to me, that's a workflow bottleneck, not a workload. It's not that they're busy, it's what has to be prioritized first. So you probably don't want the person vetting the insurance also updating this real-time board. You want people who are clinical able to do that. So there's definitely some thoughts like that came out in this medication reconciliation about where the workflow bottlenecks are in a primary care and emergency care setting.
Finally, for your own personal or professional knowledge and career, what are you hoping to gain by interacting with a lot of the healthcare process engineers who are going to be attending this conference?
Well, I've known some of them for a long time. I won't name names, but there's somebody at Ohio State that I'm excited to see again, where I am now. But yeah, no, I feel like we have a shared mission. I feel like the human factors community is a slightly different take from what's happening in this conference, but this conference to me is more exciting in some ways because it's not about the research and the papers and the academic, I went to a conference and presented. It's people who are really trying to make a difference on the ground. And it's not that I can't learn from people who are researching, but I do think the practical nature of just trying to do work and how draining that is requires you to have some successes just to keep going, Right. And so if nothing else, I'm looking to just re-energize my own batteries. I am 60% time now with the VA working on a variety of projects in pretty similar role to what I think a lot of the people, the attendees, are doing. And so, just for my own practical work, I need to learn what's happening.
Dr. Patterson, thank you so much for taking the time.
Thank you. And, if they need any extra incentive, there's a huge winter storm coming in. So go to Atlanta.
Well, you never know how it's going to go in Atlanta in February. I promise you that. Dr. Patterson, thank you so much.
Thank you.
So that's one side of healthcare improvement. How technology, workflows, and communication either support the work or quietly break it. Now we shift to another side. High reliability. How leaders design systems that anticipate human error, sustain institutional knowledge, and protect patients in the real world. Here are highlights from Lennox Wildman, VA healthcare leader and HSPI keynote speaker.
We can't stop errors from happening. What we want to do is make sure that they happen as far away from our patients as possible so that it can be resolved. And really and truly, the patient don't even know that those errors took place.
Excellent. What are the challenges that you face at a VA hospital where you then apply industrial and systems engineering principles for problem solving?
So, a lot of organizations go through this, but I think in the VA, we see it a lot. Turnover rate. So having systems in place that are consistent that individuals can fall in on is very important, because if we rely totally on the ability of someone's own knowledge to get the task done, and then we go to we end up at that one tier level of failure where as soon as, the person with all of the knowledge leaves, then no one else knows what to do. So this is a challenge at any, a lot of times at any big organization, but the VA is unique in the sense that it's a huge enterprise, and it allows intertransfers as well, just like the military does, So I'm here in Augusta, and if I see a position that's in, let's say, in California that I like, and it's the same position, I could somehow try to transfer into that position, or positions become available, I'll apply for that position. And if I'm good enough, I'll make the cut. And so you have a lot of transfer that are taking place where you may leave the organization, but you have not left the enterprise. So we have to always be thinking about that. Also, a lot of times our members are military spouses as well. And so we're sometimes close to other facilities. And so as the military member is leaving, the spouses will have to leave as well. So we're always having that transition. So again, we still must maintain a high reliability organization. And a lot of times that becomes a challenge for us to make sure that we have systems in place that are so strong that it doesn't matter who leaves. The system is in place to continue on with the service that we provide. There's a saying in the VA, if you've been to one VA, you've been to one VA. So even although it's within an enterprise, you also have to maintain what your organization does. And so the institutional knowledge is critical, because it's not a one size fit all. So even although we're all within the VA, what we do here at Charlie Norwood VA Medical Center is not what you would do in Atlanta, just an hour and a half, 2 hours down the road. So sustainability is a key factor for us.
Okay. How have you applied your experience then in the military and other leadership roles you've had to operational practices in healthcare?
Practice, 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 practice. So the military, my military experience, I'm 22 years on active duty. I retired in 2008. And I remember this thing in particular as far as success when it comes to the military. It's train as you fight. And so repetition, but perfect repetition, or near perfect repetition, right? Because you can practice something wrong, and now you're just really good at doing it bad. And so you have to make sure that you're touching all the bases. Make sure you include subject matter experts into it. And I think one of the other things that I learned from military leadership is to understand that while I may be the leader, I'm secured enough that I'm also don't come with all the answers. And so I can include the team dynamic again, which is what the military is built on. It's the team concept. So I use all of that in there. But luckily enough, in healthcare, it's basically the same thing, really, because it is a team concept. There's an old saying that, it takes a village. So the patient comes into our hospital, and it bases is a lot of different places. It's the same patient that left the OR, that went to the pharmacy, that went to the lab. It's the exact same patient, and we're all playing a role in doing our part to make sure that the patient gets a comprehensive care. So from the military standpoint, I would say is that continue to do it. Be secured in yourself, not being afraid to let others onto the team, and also to make sure that you never forget the human factor. A lot of times we think of practices and processes, and we tend to forget that those practices and processes are literally done by individuals. I will say that any hospital leader look at metrics, what are our outcomes, and how well are we doing on this sliding scale, and we compare ourselves against each other or against a national standard. And sometimes it might be easy for you to chase those things and then forget that those numbers didn't magically appear.
Right.
They were the result of someone's work. And so our employees are not robots. They have their own challenges, their own fears, their own day-to-day lives. And so you cannot forget the human factor. And by getting to know your people and getting to understand and let them see you as a human being, I think it goes a lot further than just being the leader, someone that they can trust, someone they can speak to. Personally, I look at a win for me when an employee comes to me and says, "Hey, do you have some time? I just want to talk to you about something." To me, that is a win because there's a level of trust that has been developed. So for me, those are the things, the military has taught me about taking care of your people first and foremost. The mission is important. You must achieve the mission, but never forget to take care of your people.
Excellent. That's always great advice, I think, in any organization. So for your own knowledge and career benefit, what are you hoping to gain as an attendee of the conference? You'll be speaking, I believe, on Thursday, February 12th. Who are you hoping to run into? What are you hoping to learn for your own edification?
Oh, my goodness. So this will be my second time going to this conference. And so there's just so many smart people there, right? So I'm looking to run into just about, to be honest with you, just about anyone. And there's this old saying again, if you find yourself in a room where you're the smartest person, you need to find another room. And I do believe that's that room. That's the room. This conference is that room where you go there and there's just so many smart people that you can learn from. So yes, I hope to share some things that I hope I can embark some knowledge, but I also hope in the same atmosphere to gain some knowledge as well from so much talent that is going to be in that space.
Excellent. And we certainly think there'll be plenty of rooms to walk into where you won't be the smartest person. It'll always be a room full of people smarter than yourself. And that's what I think every attendee is looking for at this conference. Lennox, thanks again for taking the time.
Thanks again, sir.
We hope you enjoyed these bonus conversations with HSPI keynote speakers Dr. Patterson and Lennox Wildman. If you're joining us in person at HSPI, make sure you stop by the Problem Solve Live booth and share what you're learning. Thanks for listening. Every great solution is a story worth telling.